Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
So my name's Cynthia Shechter, and I wanted to do this symposium so that we could discuss a little bit more flexibility in the way in which lymphedema care is provided. So the topic is, can lymphedema care be personalized in rehabilitation? The reason I wanted to do this presentation was because I find that a lot of patients have had difficult experiences in therapy, and then it makes it a little bit harder for them to be able to, quote unquote, comply with the recommendations that a clinician has made. So let's get to this presentation. So when was lymphedema therapy established? The original manual lymphatic drainage was developed by Dr. Vader and his wife Estrid in the 1930s in Denmark. The manual lymphatic drainage was a procedure that made its debut in North America in the 70s in New York. Dr. Stilwell combined MLD, compression, and exercise at the Mayo Clinic in the 1950s. Foldy established CDT in the 1970s. And the Lerner Clinic in Manhattan was established in the 1990s, where he created a center to treat people with lymphedema, and he wanted to work with diagnosis, treatment, education, self-care, and so on. There's some information at that link that is on this screen, and the slideshow will be made available to you guys if anybody would like a copy. What is the quote-unquote goal of complete decongestive therapy? We want to return the limb to the stage of 0, where it's in a state of latency, by manually accessing the lymphatic vessels and pathways. The limb size should be reduced and then eventually maintained. We're preventing the reaccumulation of fluid, preventing and eliminating the risk of infection, reducing the amount of impurities and bacteria that are often found in fibrotic tissue. And if you need additional information on complete decongestive therapy, it is available at breastcancer.org. They do a nice job of summarizing it. So I figured that we didn't have to go through the whole thing. There are 5 main components of complete decongestive therapy. We have the manual lymphatic drainage, where the goal is to reroute fluid to the healthier lymphatic vessels through a manual technique. Multi-layer compression bandaging, as explained by the Laplace law, it looks at the radius of the limb, the tension, the pressure, and the goal is to decrease the girth. That is the science behind the bandaging technique. The recommendation is generally to exercise 2 times daily to stimulate muscle pump, 10 to 15 minutes at a time with compression on. Examples of exercise have been abdominal breathing, neck and shoulder rolls, ball squeezing, heel pumps, heel slides, and actually just walking. Some people remove the bandages and go swimming. The water in the pool is certainly good for lymphedema. It actually provides a bit of a working pressure so that it continues with the sort of stimulation of the lymphatic system. Then we get to the self-management phase, where we teach our patients self-manual lymphatic drainage, compression garment use, the use of night garments, and or self-bandaging. And we're also looking at skin and nail care. So what do we do to treat patients with lymphedema, generally speaking? Most CDT therapists will do a 3-week intensive therapy where somebody attends therapy daily. They have wraps on 24 hours a day, 7 days a week, with foam, because the goal is to create a cone-like extremity. And that all has to do with the law of Laplace. People are allowed to remove the bandages at times for skincare or bathing, but it depends on the case that you're working on. We teach the patient self-MLD, and patients are instructed to perform it daily. Generally, we'll obtain a night garment and compression sleeves or gloves or stockings for daytime use to be used and worn every single day. Remedial exercises, including breathing and joint movement to facilitate muscle pump while wrapped or wearing a compression garment. We measure circumferentially every couple of visits, and we move from the intensive phase to the self-care phase of management. And that's sort of the way that the treatment progresses within therapy. But one of the things that I found interesting was some of the schools actually tell us why complete decongestive therapy may fail when it's executed by a CLT certified. What does the research say? What are the things that it demonstrates? What we've been told is MLD could have been performed improperly and the fluids being rerouted elsewhere. There was maybe perhaps some missing parts or components of complete decongestive therapy, malignancy, self-induced swelling caused by self-harm. In other words, some people may take a bandage and make it very, very tight at the middle of their extremity in order to cause a little bit of fluid pooling, actually. And then they end up with a swelling condition. So the other reason that CDT may fail is because of what they say, poor patient compliance. But my question is there really such a thing as patient noncompliance? Or do we as clinicians have to modify therapy to fit each patient? So what feedback do we get from our patients regarding the mandates of complete decongestive therapy? Here's one. I cannot miss work, and I'm not allowed to have anything on my hand or arm, so I can't wear compression garments. I can't do self-drainage. It feels weird. It doesn't seem to help. There's no way I'm wearing one of those compression garments. Not only are they uncomfortable but they seem to irritate my skin. It's too hot to sleep with bandages or a nighttime garment. This patient can't treat their lymphedema, and the lymphedema is going to progress. Within the next year or so, the lymphedema, the size of the limb, the symptoms will get worse because we haven't really created an environment where this individual would be able to comply. Is the patient non-compliant? Can we, as clinicians, treat in the gray areas? What will happen next for a patient who's forced to wear a compression garment? In my experience, the compression garment will go into a drawer, get hidden away and ignored, and the lymphedema will get worse because the patient doesn't have the tools that they need to be able to manage their own lymphedema, not because we didn't teach anything, but because the information that we gave wasn't applicable to something that they could be able to do for the rest of their lives. So why not start slow, see what a person can handle and learn, and together, between the clinician and the patient, you come up with a partnership for treatment, and you agree on certain aspects, because there is no care that should be all or nothing. We should be looking at the things that each individual has to do, because if we never look at the person, then how are we going to assist? This is something that I actually found on Facebook yesterday. This is a post from a woman who is about to start her therapy. She's discussing her experience in 2016. She said, I start PT tomorrow. I've done it before in 2016. Last time was difficult because I was wrapped and bandaged with foam, bandages, and I couldn't drive for months. You can't drive if you can't bend your foot or wear shoes. I could only shower 2 times a week, and finding clothing to wear to work was a nightmare. This time, she said, and by she means her therapist, she'll do something different so I can function. I don't have anyone to help me anymore. I did go buy a cane per her suggestion since I'm unsteady, keeping fingers crossed tomorrow goes well. Now, this patient was seen in 2016. She was treated for her lymphedema, and it seems like she was sort of left in a bit of an uncomfortable situation where she didn't feel like it was a functional solution for her to go for complete decongestive therapy. She was unable to drive. You can't get to work. You can't get to the store. You can't pick up your children. You can't really do anything. So without even knowing this person's age, one of the things that I could say is her therapist forgot about her in the equation. So one of my big things is, if we all know that muscle pump moves fluid, then why would we want to bandage somebody so that they can't bend their foot or wear shoes? That's not going to work. We need people to have some mobility so that their muscles can pump and the fluid can actually get moving. So it's sort of, I'm talking about looking at the therapy in a different way, not saying that CDT doesn't work, just that we really haven't accepted any new theories in the treatment rehabilitation wise of lymphedema since the 90s. And the world is changing and people's time is less available. There is a lot more conflict with being able to go to therapy every day, being able to have your limb wrapped as a cone, because people have to get to work, people have to be able to do their jobs. If somebody works in a deli and slices deli meat, can they wear a glove and a sleeve? No, because they're working with a very sharp blade and they can cut themselves. And if their glove gets caught, they could really hurt themselves. So did we take that into account when we made our recommendation? So my question is, can lymphedema care be more individualized and more patient-centric? I say yes, as long as we start by asking the patient questions about what may be obstacles for their care. So to actually ask flat out, how many sessions can you come to a week? How long do you think that you would be able to tolerate being wrapped? Now, most people wouldn't be able to answer this until they've actually experienced being wrapped. Why is the wrap difficult to wear if someone has had previous therapy? Is your compression sleeve comfortable? Does it give the result we were hoping for, where you're getting a reduction, or are you just having some tourniquet effect and getting a bulge at the top of your arm? Is the compression sleeve working? Can we use a more manageable, less limiting technique? Can we treat in a less structured fashion? I think we can. What can the patient do to manage their swelling independently and still live without limits? Because everybody is going to want to do everything that they have done in the past. And as clinicians and rehabilitation therapists who are always looking for functional independence, we should actually be looking for that for them. The goal of our lymphedema therapy should be that our patients should be able to live without limits and manage their swelling. So has the clinician asked, have we obtained evidence through care? Can we? What standards can we put into place to evaluate whether or not the treatment is effective in a non-invasive way and a less time-consuming way? So perhaps not doing a lymph scintigraphy. What else can we do? Have patients been told? What have patients been told, and how do they feel? Well, I think the short case that I had previously with the woman who was starting her therapy again, but was nervous because she was not able to move her foot. Patients have been told, this is from my experience, I was told I can never fly again, but traveling was my life. This makes people really angry. I will not wear compression all day as a badge of my breast cancer. I cannot lay flat for 2 to 3 hours daily to use my compression pump. I was told to never lift more than 5 to 10 pounds, but my baby weighs more than that. What do I do? I was told that even though my swelling is mild now, it will eventually become stage 4 lymphedema no matter what. I cannot follow all the rules, so I'm just going to leave my lymphedema alone and let it do what it's going to do. So for people who have all of this to say, did they really benefit from therapy and from CDT, which is complete decongestive therapy? I don't think so. I think that they were told things that really actually affected their entire lives and affected what they thought that they were going to be able to do. And it stopped them from doing things that they enjoyed throughout their lives, or even holding their own child. So did we advise these patients appropriately? Have we asked questions? We've instilled fear about the rules of lymphedema care, about the rules of wearing your compression garment, and the things that may cause an issue. We have not listened to what a patient can do to manage their condition. We eliminated the gray areas of treatment and the ability for the patient to be a partner in care. So I think lymphedema care is the only thing where there isn't a large gray area. What we have is the rules, and most conditions can be treated in the gray. When patients have a reaction to a medication, can we change the dosing? When somebody says that they're not able to use a nebulizer every morning, what do we say? Maybe use it in the afternoon. See how your breathing is. What can you do? But generally, we don't do that with lymphedema therapy. And I think if we did, then maybe people would feel more in control of their condition. I think that sometimes we forget about the psychosocial. So how can we individualize care? Treating lymphedema requires research and education. It also requires innovation, trial and error, and patient education. So a lot of my therapy involves things that have failed because I'm trying to sort of see what's going to work. The psychosocial effects of care must be attended to as well, because if all that we do is instill fear, then that's what patients are holding on to. And we should be pushing for more of a live without limits sort of lifestyle. So the therapeutic relationship is really important. Discussing things with the patient, building a rapport. So what can we do differently to build the therapist and patient bond or connection? We can initiate an evaluation by asking questions about the patient, not just about their lymphedema and their swelling, but about the patient themselves. We have to find out who our patient is and what their lifestyle is, their work, their home life, their sleep patterns, everything. Medical conditions and what are involved in the management of those conditions, because of course we have to take into account that they have other things going on in their lives. Perhaps we want to ease into a care plan, ask about previous treatment, exercise, personal goals, manual therapy. What were the things that you liked? What were the things that you didn't like? What were the things that worked? Did anything work? We have to listen to the patient's feedback and modify care each session as needed. For example, somebody may need more or less pressure manually. there may be difficulty with some of the therapeutic exercises. Are they having pain in their shoulder? Are they having pain in their leg? Is their knee okay? Do they have generalized joint issues? Is there anything that we need to know before we're starting this program so that we could actually get people doing exercises that would work for them? The research shows that making a person a partner in their care gives them a better sense of control. And ultimately, a better sense of control should lead to better ability to, quote unquote, comply with what it is that we're saying. So I always say, what our goals should be for our patients is for our patients to be able to live with lymphedema, not for it. The image on the screen was actually a gift to me from a patient. This is a woman in Cuba who lives without limits. She clearly has pretty significant lymphedema in her left arm, which was actually not even noticed by the photographer. He liked the colors in this image. The first time I looked at it, the first thing I noticed was that she has severe lymphedema in her left arm. She does not manage it. Is there care in Cuba? I don't know. Did she try? I don't know. But I know looking at her that I would love to be able to help her. I also know that there are certain things that this woman is not going to be willing to do. Just based on her whole persona, because this was how she was found in Cuba. And that's why the gentleman took the picture, because of the colors, the vibrance, the beauty. She's stunning. So my overall philosophy is to assist patients in living with lymphedema, not for it. I feel like it's important for a clinician to listen to each individual, to what each individual says about their care, their tolerance of their bandages, including time spent wrapping and being wrapped. There's nothing in this world at all that is black and white. We all exist in the gray areas, and lymphedema is no exception. It's important to treat the patients as people, not as a condition. Although complete decongestive therapy is a proven treatment, I think it is so important to modify recommendations to work with patients' lifestyle, because not everyone responds to traditional therapy well, and not everyone is able to comply with what we ask of them. So it's important to use our training as a guide, but not as a finite set of rules. When I think of the care that I give, I never follow a finite grouping of rules. Instead, I work to respond to the progress each patient is making. I modify my manual therapy by changing the amount of pressure that I use on the tissue, which helps decrease the amount of tissue fibrosis that an individual has. We know that tissue fibrosis is a backup of protein molecules, of bacteria and impurities in the system that we should really be getting out. So there's also a bit of a change, because lymphedema therapy, they used to say only use a feather touch. But actually, as I learned at the Academy of Lymphatic Studies, when I took a course with them, the firmer the tissue, the firmer the touch. I think a lot of us steer clear of excessive pressure because we're not sure what the outcome will be. But there's no reason to believe that we're causing any harm. If the tissue is fibrotic, we can break that up. We can soften it. As we soften it, then we can get the fluid to reabsorb. I change whether or not I use a compression pump, foam for my bandaging. Sleeves are often not tolerated, and the bandaging technique can vary based on every single patient. When treatment isn't modified, patients are often nervous, depressed, and angry about their condition, per the research. I find that my patients feel more in control of their condition. They're less afraid to live their lives. They're still excited to go hiking, to go climbing, to go do the things that they love and enjoy, because they're not as afraid that their swelling will get worse and they won't have any control over it. They have the tools at home to assist them if they have an exacerbation, which is what I try to do with everyone. I also try to make a treatment plan and a self-management plan that somebody will be able to follow and live up to. So, do we do manual lymphatic drainage and follow complete decongestive therapy alone? I say no. According to White and White in 1998, the practice of medicine is rarely cut and dry and typically requires a wise weighing of risks and benefits, incorporating a broad psychological, physical, socioeconomic, and cost perspective in decision-making. Rigid practice parameters and excessive warnings may raise patient fears overall. Needed medical or surgical interventions and enjoyable daily activities that could be substantially improved and will substantially improve the patient's quality of life. So the research shows that patients have an overall better result, mind, body, spirit, when all of the areas of functional limitation postoperatively or even just with primary lymphedema are addressed. So what are we working for? We're working to restore range of motion. I work on scar tissue, post-radiated tissue, to increase the vascularity of the tissue and tissue health. Soft tissue and transfixion massage for axillary web, capsular contracture, and or flap rehab, all while treating lymphedema and focusing on the patient's rehab goals. So the session may include several different things. I may be doing scar manipulation, soft tissue mobilization, and also MLD, bandaging, wrapping. In practice, we as clinicians should manage all aspects of the patient's care. So we're looking at the physical, the emotional, the psychological health is all of the utmost importance, and we can't ignore any of those areas. When we do, we're failing the patient. So this is a 34-year-old young woman who just shy of her 30th birthday was diagnosed with breast cancer. She had right triple negative inflammatory breast cancer. She had a right total mastectomy with axillary node dissection in January of 2012, and they took 26 nodes. One was positive. In December 2012, she underwent the right breast reconstruction, and she had a lat flap. And she also underwent a simple mastectomy on the opposite side with immediate reconstruction with a tissue expander. And then she had her exchange from the expander to the implant 3 months post. She was treated with radiation therapy in February of 2012 for 5 weeks, 25 sessions total, and she developed axillary web syndrome. In June of 2012, she had a sudden onset of right upper extremity lymphedema, which began exclusively in her hand and later developed throughout the entire right upper extremity. She had 2 different lymphedema therapy regimens at a different facility that were dissatisfying, and she came to me for an evaluation. So what was I going to do for her that could be different? Because clearly she didn't do well with complete decongestive therapy. So this patient, MK, was stunned by her diagnosis and did not want anybody from work or in her social network or anything to know what was going on with her. She worked in the high-end jewelry market. She had to model jewelry for a lot of the clients, and she was unable to use a sleeve and a glove while at work. Her lymphedema care was initiated with a detailed discussion of her goals, her lifestyle, her self-care ability, since she had already experienced failed therapy in the past. She stated that her previous therapist didn't know what to do once she demonstrated difficulty with the quote unquote rules of self-management. So what did we do differently at my practice? We initiated with scar manipulation and range of motion to decrease pain and complaints of poor functional right upper extremity use. Each session, I did scar massage, soft tissue mobilization, manual lymphatic drainage, bandaging, exercise, including the upper body ergometer, stretching, overhead hand pumps, And she really loved boxing, so we did a lot of boxing type activities for cardiovascular. She wore bandages for 4 to 16 hours after each therapy session. I did not use foam, and she did not wear a compression sleeve unless she was exercising, lifting heavy moving boxes, and for flying. This is the outcome of her care. Now, the image that I had on the previous slide was how her arm was a month prior to her wedding, where we were working on really getting her swelling down as much as possible because she wanted to be a beautiful bride, which of course she was because she's a beautiful human being. Her initial measurements showed pretty significant swelling in that right upper extremity. And as you go through and you look at the different slides, she had a great decrease. Oh, actually, I put the same picture twice. I'm so sorry. The last measurements, follow-up measurements, 8/4/19, I have to fix on my slideshow because those are the wrong measurements. But basically, MK was able to maintain her limb reduction with use of a compression pump at home, self-bandaging, and intermittent use of her sleeve and glove. She had a rigorous exercise regimen, including Pilates, yoga, boxing, and strengthening. And though we are in touch, she hasn't required any additional therapy. She's actually able to manage completely independently, which is exactly what we want for people. We want them to be able to keep their arm, their limb, their leg, their face in check so that they're able to do the things that they have to every day. We don't lead the lives that we led in the 30s where we were a lot more stagnant. Now we're very busy people. The world is a different place. So what's missing? If you ask me, data. We need to find out whether or not this treatment regimen is going to work. So one of the things that I did at my clinic was I actually got the ImpediMed LDEX. And I'm looking at the impact of the LDEX and its impact on care. Can the LDEX take up data and get us further in treatment and in the establishment of appropriate treatment goals? It can give us proof that treatment is successful clinically. We can demonstrate and look at the changes in tissue textures and its effect on fluid levels. Patients with increased tissue density will likely actually demonstrate less intracellular fluid initially than a patient who has very low fibrosis. If the increased tissue, if there is an increase in tissue density and a decrease in fluid, then what I would expect is as we break up that density, that fibrotic tissue, perhaps that would actually increase the intracellular fluid initially. And then we would look to decrease those fluid levels. So initially you're working on increasing the tissue health and getting rid of the tissue fibrosis and the backup bacteria. And then you're working on decreasing the fluid levels. It makes sense in my brain. I need more research. Fluid levels will increase initially while working on breaking down the fibrosis, which is what I just said. Once tissue is more malleable, we can modify our pressures. If somebody's tissue is significantly softer than it was when we started, then we shouldn't be using the same amount of pressure. We should be lessening up on the actual pressure and working more on a little bit more superficial manual lymphatic drainage to try to get the fluid levels down again. I believe that the ImpediMed LDEX or anything that measures fluid levels could help us through the stages in care and continuing to personalize the intervention. If we're doing an LDEX measurement, say every 2 weeks of a patient's care and we're seeing somebody 2 times a week, then at some point we should be able to actually see from the measurements that our care is working. And if we see that our care is not working, then what are we going to do to make sure that it does? So that's kind of what I'm thinking in terms of the research that needs to be done, the data that needs to be compiled, and I'm curious what it'll show. So far, I've had a pretty good result. Here's a case study of SG with the LDEX data. So you can see her circumferential measures were taken 4/9 of 2021. She had significant swelling in her left upper extremity. She's also experiencing metastatic disease, and it is not 100% controlled right now, even though she is being treated. So those were all things that I took into account at the time of the eval. And I take into account for our treatment sessions because, of course, she has different needs. So, okay, you can see the decrease in girth measurements. But to me, girth measurements are always very subjective because we don't know how firmly somebody pulls the tape measure. We don't know if we're in the same exact location. If our tape measure was slightly off, then are we still measuring the same spot? There's a lot of unknowns. So I think the LDEX gives us a little bit more data. It gives us something much more definitive. So as opposed to circumferential measures, the LDEX actually shows the decrease. So when somebody gets on the machine, when she was initially evaluated on April 9th, 2021, her LDEX score was a 13.6. A month later, despite the fact that her medication wasn't working and she was having a bit of an exacerbation of her lymphedema, on May 10th, when I did a new measure, she had decreased by almost 3 points, which is significant in that I am not treating based on the girth measurements only. I'm not treating based on anything. I'm treating with everything that she has told me she would be able to do. And it's working. It might be a little bit slower, but overall, she's not stressed out about her lymphedema. She's stressed out about a lot of other things, but her lymphedema is being controlled. We are working on it, we are getting it down, and she's pleased with her results thus far. So let's talk about her. Let's talk about SG and her healthcare plan. She was diagnosed with stage 4 Müllerian carcinoma and has been undergoing chemotherapy treatment. She lives at home with her parents, exercises avidly, works full-time in business, and is currently single and was dating until March of 2020 when COVID began. She presents with significant right upper extremity swelling, most prominent 10 centimeters distal to 10 centimeters proximal of the elbow crease, and she has breast swelling. She's had cellulitis twice, both times requiring hospitalization, and IV vancomycin for 5 days. Per the patient, there is no upper extremity lymph node involvement in her cancer. Now, that was something that I kept in mind the entire time I was treating her, because it didn't make sense to me that there was breast swelling and arm swelling, but no lymph node involvement. I later found out that there was. What were her therapy goals, though? What was she hoping to achieve? Because that's pretty important, if you ask me. So she wanted to remain infection-free and continue her full-time employment. She wanted to move out of her parents' house. She's 38 years old, by the way. She wants to get back into her pre-chemotherapy physical state and exercise routine. She wants to stop her swelling so that she could wear clothes and look quote unquote normal. She wants to stop having aching in her arm and her breast, and she wants to live her life since she may not be here for as long as she thought. That was a little bit hard to hear as a clinician, but it is valid. So she regained her full range of motion, decreased girth and aching in her upper extremity. She uses the Eros pump with the chest component to keep tissue and fluid soft and moving. She has a compression sleeve for use at the gym and uses a Caressio garment 3 to 5 nights weekly. She uses either a sports bra or a prairie bra for compression of the breast, and she's very happy to, quote unquote, look normal, be able to do everything she wants and needs, travel, date, work, and just live her best life. She has no fear of her lymphedema, as she has not been overwhelmed by the rules of management or precautions. Self-manual lymphatic drainage was not prescribed because the patient was uncomfortable with the possibility of error. She bandages to exercise at least 1 time weekly to obtain a good muscle pump to facilitate lymphatic flow. And she comes to treatment basically one time a month to check in, to see what her status is, and to ensure that she stays on her path to wellness. That to me is so important for somebody with cancer, particularly somebody who is 38 with stage 4 disease. I wouldn't want her to be afraid. I would want her to be able to sort of embrace this part of her care and be able to live with a little bit less fear. So let's go back to the LDEX for a moment. We're looking at its significance. To me, we have to figure that out. But if SG's LDEX score continued to decrease and infections remained controlled, and the patient was less symptomatic, then individualized care planning and lymphedema care worked for her. Every single patient is different, but measurement techniques are so limited and most are pretty subjective. The LDEX would allow true monitoring of recovery while allowing a clinician to maintain their focus on treatment, not on the need to take new circumferential measurements every couple of visits. Actually, taking the measurements is really time consuming, and patients actually lose a lot of the manual on that session itself. So what would the benefits of a flexible treatment planning for lymphedema be? Well, the patient's psychosocial needs are addressed from session 1 on. Manual therapy would initially focus on decreasing symptoms of discomfort. And then that focus would include the manual lymphatic drainage, the bandaging, and care is implemented as a team, client and clinician. The criteria for maintaining swelling reduction for the patient is as easy as possible and requires as little time from the person themselves to attend to their lymphedema, because that will also help them feel like they're not going to drown in self-care for their lymphedema. So I wanted this presentation to sort of pique all of our interests, to sort of get things back to where we want them to be, so that the patient can be motivated to take care of their lymphedema rather than despise taking care of their lymphedema, which I think happens. So I'm hoping that now we can do some questions and answers. Should CDT include psychosocial support for dealing with a chronic illness? My question mark key doesn't work. Okay. And so, if so, how could it be integrated in the so-called gold standard of care? Yes, 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 Adrian. Psychosocial support is so important. And I think if people are unable to deal with what's going on in their bodies, then how are we supposed to help them feel better? What are we supposed to do? I think dealing with a chronic illness is a horrible thing. And if we could all, as therapists, listen a little bit more and actually give people resources. We can provide names. We can refer to one another. If my type of therapy doesn't work, I do not have a problem sending a patient to somebody else for care. I think that that is what should happen. My technique isn't for everyone. My technique isn't for people who have severe swelling. There are rules that have to be used depending on the clinical status. So, okay, so Emily says, as a patient, I have the opposite problem. I'm compliant, wear compression day and night, exercise, pump daily, and get MLD once to twice a week. But she's never been able to get CDT because there isn't the availability from lymph therapists. How can I advocate for this level of care when there's a shortage of therapists? Well, that's an interesting question. There is definitely a shortage of therapists, and I think that's a real issue. But I think that we are missing one question, which is, how come what you're doing now isn't working? What is it that's missing? Did we miss something in your care? Did we miss something in your self-management phase? There has to be something missing there. I mean, there are a lot of therapists who follow complete decongestive therapy. And I'm wondering, Emily, if you went back to wherever you went for care, if you were able to ask them if they could just follow standard of care for complete decongestive therapy. I wonder if they would. Daniel asked about homeopathy. Sure, I think do I know if homeopathy works or doesn't work? No, but that's just it. I think anything can be added or subtracted from somebody's care. So sorry, there's an ambulance. Anything can be added or subtracted from somebody's care based on what it is that they need. So if you want to try homeopathy, even acupuncture, people try many, many different sorts of things. Perhaps if we did that better and we did a better job, we would be more able to assist people. I do recommend homeopathy at times. There are different vitamins for lymph support. My patients who get chronic infections, sometimes I say, maybe you should speak to your doctor about oil of oregano supplements, because they do help to decrease infection. There are so many different things that you could actually do. So as far as each session, my sessions are all an hour of manual therapy, followed by exercise in the gym that is separate from the manual. So the manual is an hour. That includes the bandaging at the end, but because I don't use foam, bandaging is pretty fast. And there's a YouTube video of me self-bandaging my arm, and you'll see how quickly it actually goes on when you decrease the amount that you're doing. The LDEX, Adrian, I could try to explain, but I think that the ImpediMed people might be upset with me because I'm probably going to do it a disservice. What I think, though, is that the LDEX is a machine that you basically stand on. You're barefoot, your hands are also bare. The area where you put your feet and your hands are wet. They have to be, because that's how the impulses are sent through the machine. You stand on it, and it actually gives you a measurement of intracellular fluid. It can also give you a body composition measurement, which I haven't really figured out how to apply because I just got my bioimpedance. So I just got the machine. I am still learning how to read the results, and ImpediMed has been wonderful in educating me. So if any clinician out there is a little bit nervous about getting one, they're great. I like to have an actual measure of the fluid level so that I could see whether or not things are decreasing. Judy asked about my take on surgical intervention. I mean, I certainly don't think there's no harm in going and finding out whether or not you're a candidate for a procedure. Do I think that right now, lymph node transfers or lymphovenous bypass is curing lymphedema? No. what I've seen as far as the surgeries are concerned is that, and this is just based off of my clinical experience, is that people who have chronic infections, chronic cellulitis, generally, the people who I've seen who have had lymph node transfers and had chronic cellulitis did not have chronic cellulitis post lymph node transfer. To me, that's a successful surgery. I've never seen somebody's swelling completely recover, though I did just speak to somebody in New Jersey who told me that she had a lymph node transfer 4 years ago, and although her arm is still swollen, her symptoms are so significantly decreased that she's really, really happy. So I think surgical intervention is for some. It's not for everybody. But it's worth asking. So go have a consult, see whether or not you're a candidate, see what others are recommending for you. Always ask questions, because that's the only way you're going to be able to, it's the only way you're going to be able to figure everything out and piece things together. Rebecca, I actually answered your question, yes, on the LE&RN site. I did it yesterday. I really can't comment on the research because because I have to read the whole article, honestly, and I can look at it, and if you'd like, if you provide your email, I can certainly email you so that we could discuss the article further. But I'd have to review all of this research from Australia so that I could actually speak to it. But I will say that in Australia, what they are finding is that they are modifying treatment. They are doing things a little bit differently, and it's working. But I have to reread the article. I apologize. So. Asking, okay, so Bonnie wants to know, all the questions keep writing up. Okay, Bonnie wants to know the best way to enjoy swimming with lymphedema, stage 2 in the left arm. I'm not sure of what that question is. I think you should enjoy swimming. When you go swimming with lymphedema, you should not generally be wearing compression. You should just be swimming. So it's a matter of whether or not your scar tissue is released, your range of motion is good, and the strokes feel good. But any motion in the water is going to help you decrease your swelling. So I would say there is no best way. There's just swimming, and you should enjoy. Leora asked, why don't I use foam for the bandaging? I don't have anything against foam specifically, but I really like for my patients to be able to move. I believe that muscle movement moves fluid. So to me, when I wrap people with the foam, I am limiting their motion. I am taking away their ability to bend, to reach, to use their arm functionally, which is, in my opinion, not what I want to do. I want to wrap them and have them using their arm as much as possible, because of course that muscle pump while they're wrapped is going to get that swelling to go down. So I don't find the need for the foam. It's not that I have a problem with it. I just prefer the less is more technique, and most of my patients just don't require it. I may make a chip patch or pad. I may use something like I actually have it right here. I may use a Jovi tab, which looks like this, where you're putting it in a certain area to break down some of the tissue fibrosis, but I don't find it's necessary to use the gray foam, to bevel it. It's very time consuming and very difficult when you go to teach your patient how to self-bandage for them to stabilize those pieces of foam and get their bandaging on properly. There's too many components that are loose. So I try not to use it. Okay, Karen asks, I am using a new pump that allows me to manage the pressure. I'm finding good results with high pressure, but wonder if I could damage the lymph nodes. Can I please advise? So from what I understand, you could have your pump set all the way up to 80 millimeters of mercury and you are not damaging lymphatic vessels at all. The idea is the pump pressure should match what your extremity needs. So if you have a lot of tissue fibrosis, perhaps you would want your pump to be at a higher level because you really want to break that down. Sometimes you even put something like the Caressia sleeve or a Faro sleeve underneath, a chip sleeve, so that that actually works into the tissue and breaks it up. You can go up to 80. I generally don't pump higher than 45. But that's me, and that's because I'm older, honestly. And when I initially learned about using a compression pump, I was taught lower levels, and 80 just sounds high. But that is certainly not a clinical answer, so please don't take it as such. I'm just reading from Melissa. After successful bandaging, what do you do when a patient wants to quit wearing arm compression garment due to hand swelling and doesn't improve with additional compression glove? Is this a symptom of a garment that is simply too tight around the wrist? Are most compression garments customizable for a wrist measurement, or should bandaging be resumed? It is so important to continue compression, but it seems that problems commonly arise once the switch from bandaging to compression garments happen. Exactly, Melissa. So that's sort of my point, is that we're not giving people the in-between. We're not providing them with what they need to be able to self-manage. Compression garments are interesting. There are a lot of things about compression garments that are wonderful, and there are a lot of things about compression garments that are terrible. What I will say is I try to keep my patients out of custom garments. Number one, they are so expensive. Number two, they would only really 100% fit if they put them on the day that you ordered it. The problem is the extremity is always changing. So a lot of clinicians will order a custom garment that was measured to fit their patient at the time that they were sort of discharged from therapy and they were ready for self-management. Sometimes what happens is the garment doesn't come in and the patient's discharged and they don't self-bandage and they're not really doing anything in between, and they end up with an accumulation of fluid, and then they get their garment and the garment's too small. A lot of compression garments actually can cause pooling of fluid. So if it doesn't fit right every day, if it's too tight around the wrist, then the hand is going to blow up. If we don't give distal compression, is the hand going to swell? Has the patient ever experienced swelling in the hand? Most compression garments are customizable, but like I said, we have to remember that that extremity is always going to change. So no 2 days will be exactly alike because fluid levels in the body shifts. And that's just natural. So if natural fluid balance switches, then what? So I think compression is important, but if it's not working, what are we going to do, Melissa? I think that what we're going to do is decrease the wearing of the compression sleeve, perhaps increase the muscle pump. Does that mean you have to start bandaging all over again? I don't know that bandaging needs to completely stop. I actually love it when my patients self-bandage at night. If they do it 3 times a week, I find that it's very successful. And most of my patients do not wear compression during the day. They wear compression if they're lifting, they wear compression if they're flying, and they wear compression if they're moving like heavy boxes or they're doing anything with like complete repetitive movement. There's always a place for a compression garment, but it doesn't need to be the entire discharge plan. My discharge plan for my patients is I never have a goal of fit with a compression sleeve, because I feel like, of course, I'm going to fit you with a compression sleeve. I'm just not going to have you wear it all the time. Maria, hi Maria. Maria and I used to work together. Maria asks, what do you use instead of foam to bandage? How long do your clients keep the bandages on? And if they have to go to work, etc., do you use other options instead of bandaging? Okay, so instead of foam, I just use Artiflex. I don't find it necessary to create a cone shape. I actually think that the muscle pump is better when the bandage is close to the skin, when it's actually working on the areas that you need it to. So I'll use Artiflex always at joint creases, the wrist and the elbow crease. Sometimes I'll use it all the way from the hand, all the way up the arm, underneath. It just depends. It depends on what I see in that one individual patient. Other options than bandaging, yes. Do I use them? Sure, but not in treatment. So when they're in treatment, I definitely bandage. When we're looking at home management, one of my favorite things is the tribute sleeve or the Caressia, which is an off-the-shelf version. The off-the-shelf version is, it's a good garment and it works for people. And similar to off-the-shelf compression sleeves, it seems to be able to maintain things without an exacerbation being present. So I hope that answers your question. And I hope that all of my answers are actually answering your questions, because sometimes I do go off track. So if I didn't answer your question, please re-ask at the bottom. I'm happy to answer. Adrian says, thanks so much for your open-minded and open-hearted approach to lymphedema and the people who suffer from it. Compassion is key. I agree. Thank you, hon. Can I talk about night and day garments and which types names, please, have I found most helpful? For the foot and the leg. Okay, so Adrian, I could do this offline, but generally I can't recommend a specific garment on this presentation. But if you provide your email, I am happy to discuss. But is there a best garment for a patient? Not really, because I don't know every patient. So we have to figure out first what a patient needs. There are a lot of different night and day garments for leg swelling, for example. I have patients who will use one thing for when they go out for a run, something for when it's at night, something for during the day. And there's so many different kinds. But Adrian, like I said, I'm very happy to discuss it with you offline. And thank you. I'm glad that this presentation was at least effective. Catherine, thank you, Catherine. I'm glad that you like this. You agree therapists should personalize. Unfortunately, many are not taught to use their critical thinking skills. Exactly. So Catherine just touched on a very interesting point. So we are trained clinicians. So I'm an OT by practice. I was an OT prior to being a lymphedema therapist. So when I became a lymphedema therapist, I didn't want to change my way of evaluating a patient, because I feel like it is all very individually focused. So to me, it would be wonderful if all of us could listen to our patients and figure out what will work the best. What is it that we could do for someone that would really be the one thing that would make the difference for them? Because there are so many things that just don't work. So I always say I was a clinician first, and I was a lymphedema therapist second. And my clinical skills from being an OT and being a clinician have to take over prior to what it is that I'm going to say about anybody's swelling, anybody's anything. I have to take into account all of the critical thinking skills that I did learn in school, that I was able to to use, and that actually were an enlightening and helpful thing for patients. So Arati, I hope I said that right. I hear that there's a shortage of CLTs. I've been a CLT since 2018, but I'm unable to find a job in this region. What sites are lymphedema jobs posted? I have no idea. I'm so sorry. I don't know the answer to that question. I think that you just have to continue to look, perhaps contact hospitals, perhaps if they don't have a program, maybe talk to them about starting one, and maybe that would be your in. I think, you know, starting a program for somebody else is a wonderful thing to do, and it's only going to help you succeed. So I would say perhaps connect with another clinician so that you have somebody else to answer some of the questions and see what happens. Seema said, is wearing a compression sleeve or bandage a relative or absolute indication for during flight? So during flight, you have to wear something if you have lymphedema. If you've never been diagnosed with lymphedema, that's okay. I think my patients who do not have lymphedema don't wear compression on a plane. I don't like it because I feel like it invites an issue. And I don't want to do that. It is something that you have to do to fly because of the barometric pressure changes on the plane. Usually I say, I don't care if you put your compression sleeve and glove. I like a glove because I don't like the opportunity for fluid to go into the hand. When you're flying, I don't care if you put it on when you're sitting in the seat at the gate, it's fine. But for the flight and 2 hours after, 1 to 2 hours after, I usually say leave it on so that your body can readjust. And once your body reacclimates, then you take it off and you should be good. But it is kind of mandatory to have something to fly. Okay. Which questionnaires or instruments do I use for measuring the results of individualized treatment? I use a lot of them, actually. Which ones? That's the question. Let me find my screen. I use the DASH. That's easy for upper extremity. For lower extremity, I use the LEFs. Those are the two easiest ones to use. I also use the distress thermometer and problem list for patients. So I don't know if you've ever seen this, but this is the National Comprehensive Cancer Network distress thermometer test. There it is. Now you can see it. I really like this because it gives me a quick answer to how somebody's doing. It tells me what their problems are that are practical. It tells me their problems that are family, emotional. Do they have spiritual concerns? And then we could speak to everything. And of course, I also ask about how they're feeling as far as their distress. I do the psychosocial. I like to use some functional measurements, but I also do use the LDEX. So functional measurements are wonderful, and there are a lot of them out there. So I think that is important. So I think that answers Adrian's next question, including imaging. Do you believe? Oh, so do I believe in imaging? Well, prior to treatment, I do think that if somebody has new onset swelling, they have to go to the doctor. They have to make sure that they don't have a blood clot and there's nothing else medical going on. As far as the lymph scintigraphy or the SPY test, I think that there are always reasons to have it. You can find the areas that are backed up. But if you're not working directly with the doctor who's doing the test, it really, in the end, shows that there's a blockage in the lymphatic system, which a lot of times we already know. So it's sort of contingent upon what you see. And to me, the diagnostic tools that make sense are the ones that I use. And I don't like people to have to go for the SPY or the LEFs or the lymph scintigraphy, simply because I think that it predisposes them to a risk factor, right? It makes it so that you're having needles put into your skin between the web space, you have dye that is visible, and that is something that we need to pay attention to. All right, I'm trying to get through all the questions. So Carmela asked, you can make easier to use gray foam when you sandwich in between 2 layers of stockinette. That is true. Thank you. That's true. So if anybody wants to use foam and is having a problem, you could sandwich it between stockinette and it will be helpful. Thank you, Marilyn. I'm glad that you find this helpful. Oh, really? Oh, you just saw Dr. Green. That's wonderful. I'm talking to Karen now. I apologize. Thank you. I'm glad that you enjoyed the presentation. Lymphedema is not black and white. That's exactly my point. I think that the outside of the box thinking is the only way that we're going to be able to help people and really, really actually help people. And I think that back in the day, CDT was great because it worked really well and we didn't have active lives. So, but now things have changed and there are so many things that we can do. Seema, yes, I do a lot of kinesiotaping along with bandaging. Sometimes I don't even do bandaging and I just do kinesiotaping. It really and truly for me depends on the patient and what the patient really, really wants and needs. Because if you have somebody who is just not willing to walk around with bandages, can kinesiotape actually take its place? I've had a lot of particularly lower extremity patients who kinesiotape has worked wonderfully for. But I am very cautious because people do have reactions. Sometimes I even use a little bit of milk of magnesia on the skin underneath the tape. If you put it on with a cotton ball and let it dry, it creates a bit of a separation for the skin so that it doesn't get irritated. Some people have just horrible luck with tape and it just doesn't work for them. And for some people, when it's post-radiated tissue in particular, I try to keep the tape off the radiated tissue. But sometimes patients who have had breast cancer and breast cancer surgery end up with Mondor syndrome, which is basically, it's a cord that comes underneath the breast. And for that, I find kinesiotaping really, really helps. But I teach the patients to wet it and make sure that they're not pulling at the bandage for removal, that they are actually just rolling the bandage off the skin. So they're sort of just doing this, and that makes it so that they're not pulling, and it shouldn't damage the skin that way. Sometimes people are just very reactive. So usually I do a patch test. I actually did one for a woman yesterday. So we'll see what happens there. Gwendolyn, thank you for this. Thank you for saying that. I don't have definitive lymphedema, but ended up with chronic swelling and pain in my arm, breast, and hand after a plasma donation disaster. Well, that's terrible. She does okay with MLD, but she's frustrated and doesn't know for sure if it's lymphedema. So I think sometimes, okay, so let me just read the whole thing, but it's certainly managed best with MLD and my own Feldenkrais movement lessons for pain control and functional gains. In Canada, she's in Canada, and they don't seem to have a great system for diagnosis that isn't from a straightforward diagnosis treatment of breast cancer because it has to be studied more. That is correct. I have to limit so much of what I do because so much that I do will cause swelling.
I like the living a better, larger life with fewer limitations. Ideas for definitive diagnosis. I also never got the hang of self-wrapping. All the wrapping and garments make me so itchy. I elevate, move my limb a lot, but am super restricted in lifting any weight. I'm so confused at times. Gwendolyn, it sounds like you are in a very frustrating situation right now, and I'd love to help. I think, so lymphedema is a difficult diagnosis, and usually it's one of elimination. So most people who are being diagnosed with lymphedema, they're being diagnosed with lymphedema once we rule out that there's a blood clot. Any sort of chronic swelling is really a lymphedema. They're even saying now that swelling from post-operative things like a knee replacement, those situations are actually being labeled as lymphedema. The diagnostic care is not really as important as the actual care. And I know it sounds weird, but if somebody has a chronic swelling and it doesn't go away, and there's no malignancy, and there's no blood clot, then I would say it's a lymphedema because it is a chronic swelling. I think that we would need to really evaluate to see what's going on. And you're right, there needs to be so much more research. There needs to be research on everything. So lymphedema is an underfunded, under-researched disease. And that's actually why the Lymphatic Education and Research Network exists, because they want to increase awareness and they want to get everybody feeling better. And we don't want people to have to suffer. And we don't want people to feel as out of control as you do, Gwendolyn. And there should be things that we could do. So I'm actually going to encourage you to message me, because I think that that would be helpful. I'd like to talk to you a little bit more about you prior to giving you any recommendations, but it sounds to me like you're just in a very frustrated state. You know Feldenkrais, you're familiar with your body, you're used to doing exercise. We have to get you back. So certainly contact me. Okay, Dina says, I have left arm secondary lymphedema and was recently diagnosed with tendonitis in that arm, together with a flare-up of my lymphedema. The orthopedist I am seeing for the first time next week is already considering a counterforce brace. And my lymphedema therapist is not so sure. We think it may cause more swelling. Do I have any thoughts? Yes. He's going to give you, more than likely, if it's a tendonitis and it's a lateral epicondylitis, you're more than likely going to get the strap that has the little air pillow that sits on your forearm and it wraps around. And yes, there's a risk that that could cause increased swelling. A lot of times, actually, lateral epicondylitis could be treated with a wrist splint because it's actually an overuse of your wrist extensor. So I think perhaps let's not put the cart before the horse. Let's see what the doctor says when you go, and you'll speak to him about your concerns, about the things that are sort of not working out. And they'll talk about, you can work it out with the doctor. If the strap is bad, which I agree with your therapist, the likelihood is putting an elastic strap in the middle of your forearm is going to cause fluid pooling. I think that is a reasonable consideration, and speaking to the doctor is the best way to find out the answer. And that is actually the end of my questions. So, oh no, it's not. I apologize. I did not tell the truth. There's two more and then I'm going to be done. So what do I recommend a patient should ask a new clinician when they are considering starting treatment? It depends on the person. I think that you can certainly ask, are you able to be flexible in the care? Are you able to do you look at me, or is it that you treat lymphedema? Do you follow the certification, or do you stray from what the certification educators say? You should really look for everything. And I'll try to provide, I have somewhere a list of things that patients should ask when they go to a new therapist. It's in one of my books. I will find it and I'll send it to somebody at the Lymphatic Education and Research Network, and hopefully, oh no, actually, I'll send it to you because I believe you sent me your contact information, which is great. So I'll be in touch. SEMA, can MLD be done to a patient on antibiotics for lymphangitis? Of course. Even if somebody has cellulitis, after 24 hours of antibiotics, a patient is cleared to participate in therapy. You're no longer spreading the infection. So yeah, I mean, if you want, wait 48 hours, but you could certainly treat. I hope that this presentation was helpful, a little bit eye-opening, and maybe just gave people some thoughts as to what could be done differently for you. Oh, I forgot one question. I had a modified neck dissection followed by chemo and radiation to the neck. I have neck lymphedema. Why does the focus seem, well, so unfortunately, I'm so sorry, Patricia, you're right. The focus does seem to be on the extremities because it's the most common area for lymphedema. It's also the most researched area of lymphedema, and the face and neck, head and neck lymphedema is a totally different ball of wax. So there are a lot of things that could be done for head and neck lymphedema. There are manual techniques. I actually just participated in the core certification, and in doing so, I was able to get additional information about what would be appropriate. And I also learned a lot about use of the FlexiTouch specifically for facial and neck lymphedema. And they are really the only company that has something for head and neck swelling. So perhaps you should look into that. There is manual therapy. There is also kinesiotaping. There are kinesiotaping techniques to get rid of some of the swelling in your face. There are things that can be done. So I hope that you don't feel helpless. I hope that there's somebody in your area to help you. And to all the people out there who are not therapists at this time, maybe think about how you want to be one. What is it that you want to bring to the table? And can you help make any changes? So thank you all, and I hope that I was helpful.